Welcome to our webinar. Good morning, good afternoon, and good evening. I'm your host, Ulrike Reichert from Nutrition. If you have any questions or technical issues, you can chat with me through the chat box on the right-hand side. And again, warm welcome. And with that, I would like to pass the baton on to my colleague, Rachel Powers, who will lead us through this webinar. Thank you.
Thank you, Ulrike, and thank you to everyone for joining us today for our webinar on maple syrup urine disease with our speaker, Dr. Kevin Strauss. As Ulrike said, my name is Rachel Powers. I'm the Medical Affairs Associate for Metabolics at Nutrition North America. A few technology-related items to review. All attendee lines have been muted for the webinar. As Ulrike said, if you have any questions about the content or the technology, please type them into the chat box on the bottom right side of your screen. We will answer questions at the end of the presentation. The handouts for today's presentation are available through your Nutrition Learning Center profile, where we will also plan to post the webinar recording within the next few weeks. I am thrilled to introduce our speaker today. Dr. Kevin Strauss is a board-certified pediatrician and the medical director at the Clinic for Special Children in Strasburg, Pennsylvania. He received his medical degree from Harvard Medical School and completed his residency in pediatrics at Boston Children's Hospital. Dr. Strauss joined the Clinic for Special Children in 2001 and became its medical director in 2008. Since its founding in 1989, the independent nonprofit Clinic for Special Children has evolved into a unique combination of primary care clinic for the medically underserved Amish and Mennonite communities of southeastern Pennsylvania, as well as a center for cutting-edge diagnosis and research for rare genetic conditions. In his role at the clinic, Dr. Strauss oversees all clinical services and associated research. He has co-authored over 60 peer-reviewed journal articles and has given lectures on his work all over the world. Thank you so much for joining us today, Dr. Strauss. With that, I will hand it over to you.
Okay, well, thank you so much. Thank you, Rachel and Ulrike. I'm really pleased to be with you here today, and thanks for taking time out of your busy schedules to join us for this educational event about a topic that is near and dear to my heart, has been a focus of my clinical and research work now for about 25 years. Today, we're going to be talking about maple syrup urine disease, also known as branched-chain ketoacid dehydrogenase deficiency. And I'm going to be covering what we currently know about the pathophysiology, management, and outcome of this rare genetic condition based on our experience at the Clinic for Special Children. First, my disclosures. The main disclosure is that Nutrition North America has supported the clinical development of the medical foods that we use to treat maple syrup urine disease, and also funded some aspects of the long-term follow-up study that was conducted to ensure the safety of these medical foods. I receive no personal compensation from Nutrition and hold no shares in the company. First, let's start with the pathophysiology, and I will cover this at a relatively high level. Many of you are aware of the basic biochemical defect of MSUD. MSUD affects the degradation of 3 essential amino acids, leucine, isoleucine, and valine, shown at the top. These are what we call the branched-chain amino acids. These first in their degradation pathway go through a transamination step. You see here there's a common enzyme, the BCAT, that actually converts each of these to an alpha keto acid by removing the nitrogen group from the amino acid. They then are degraded by a common complex, a multimeric complex, the branched-chain ketoacyl dehydrogenase. This is composed of 3 subunits. The gene symbols for those are BCKDHA, BCKDHB, and DBT. What we call biallelic, or 2 mutations in any one of these 3 genes, causes maple syrup urine disease. The vast majority of MSUD cases are caused by mutations of either the BCKDHA or B gene, and those cases are about equally divided between these 2 genetic types. A much smaller proportion of cases are caused by DBT mutations, and those types tend to be, but are not exclusively, less severe. The basic biochemical problem is that you have a paucity or a reduction of downstream metabolites, but more importantly for the pathophysiology is the accumulation of leucine and its alpha keto acid, what's called alpha ketoisocaproic acid or 2-ketoisocaproic acid. Classically, we think of MSUD as causing neurotoxicity in both an acute and chronic form. And it's important to recognize that although the brain expresses some branched-chain ketoacyl dehydrogenase, the large majority of it in the body is expressed in muscle and in liver. But we really think of MSUD as a brain disease. And this has to do with the way in which leucine and alpha KIC impact normal brain function and brain development. Generally, in the acute phase, and this is the aspect of MSUD that for those of us who care for the disorder find so terrifying, and even after 25 years, each time I admit a patient with acute metabolic encephalopathy to the hospital, I find it to be a very stressful experience. This typically occurs in the context of some type of infectious illness or other catabolic stress. So dietary indiscretion, extreme dietary indiscretion, can in principle cause acute toxicity from MSUD, but that's exceedingly rare. More commonly what occurs is during some type of infection or catabolic stress, the body, as part of its normal response to that stress, breaks down muscle protein. That leads to the release of branched-chain amino acids into the general circulation. Normally, those branched-chain amino acids would be used by the intestinal mucosa, by lymphocytes, and by liver cells to support what we call the acute phase response. So this would involve the synthesis of antibodies, new lymphocytes, gut mucosal cells, and then also the production of things like glucose and acute phase proteins and clotting factors, all of which help our body adapt to stress. When this normal physiologic response occurs in a patient with MSUD, we have the accumulation of leucine and alpha ketoisocaproic acid, often to very high levels and very rapidly, and they can't be further oxidized. When they accumulate in the circulation, they're taken up into the brain and they exert toxic effects. This is what we call an acute intoxication model. It is significantly different from a physiologic point of view from what we consider the classic organic acidemias like glutaric acidemia, propionic methylmalonic acidemia, in that we can really predict with a high degree of reliability what the encephalopathic state or the neurological state of the patient will be based on measurements of these chemicals in the blood. This is not the case with many organic acidemias, but with MSUD, the neurological status of the patient really does correlate very closely with the levels of measured metabolites in the blood. Now, MSUD occupies kind of a unique position among all of the inborn errors of metabolism. And the reason for that is that most organic acidemias and amino acid disorders are divided along a line of whether the primary toxin is an acid, an organic acid or a keto acid, or an amino acid, and whether it has a nitrogen group on it or not. MSUD occupies this unusual position of being both an amino acid disorder and an organic acid disorder. And the reason for that is that both metabolites are toxic to the brain, leucine and alpha KIC, but they're toxic in different ways. This is just sort of an overall diagram. It's a little bit complicated, but I put it up here to make the point that most of the leucine during acute illness is derived from body protein, which constitutes about 11% of body weight. Here you see in the lower left corner, represented by a blue circle, the sort of reservoir of body protein that can be degraded and synthesized. And during the acute phase, it's that balance between degradation, represented with a D, and synthesis of new protein that really is what we try to leverage to get the levels down. This is the basis for so-called anabolic therapies, high glucose infusion, insulin infusions, and so forth. The leucine elevation, as I'll show you in the next couple of slides, leads to the obstruction or the interference of uptake of other amino acids into the brain. So it primarily acts as a blocking mechanism to starve the brain of other amino acids. Alpha-KIC, on the other hand, here shown as purple triangles, enters the brain through a separate passageway or separate gate called SLC16A1. And actually, it exerts direct toxicity on neurons. It appears at high levels to poison mitochondria and lead to depletion of ATP and accumulation of lactic acid. It also appears to be directly involved in interfering with the volume regulation of brain cells. And this ends up being very important because it probably, alpha-ketoisocaproic acid is probably the root cause of the most feared and life-threatening complication of MSUD. On the left-hand side, you're seeing a cross-sectional CT scan of a normal brain. And in comparison, on the right, you see the brain of an MSUD patient during acute encephalopathy. Here, what you really see is you see profound brain swelling. On the left-hand side, all the black areas would be areas of normal cerebrospinal fluid. You see on the right-hand side, all of these are obliterated because of the swelling of brain tissue. And the surface of the brain is pressed up right against the inside of the skull. This will increase the pressure inside the skull or restrict brain blood flow. And if it progresses, it can lead to what we call a brain herniation, where brain tissue passes down through the lower brainstem and actually can crush blood vessels and vital structures of the brainstem. This is the principal cause of untimely death in MSUD. And so if you've had the unfortunate or tragic experience of having to treat an MSUD or patient or being involved with an MSUD patient through a fatal outcome, it is very likely that this was the cause of the fatal outcome. More important to the day-to-day management of MSUD, and probably more important to the long-term outcome, is the idea of chronic neurotoxicity. Now, we talked about the acute neurotoxicity because for patients and their families, the risk of acute metabolic encephalopathy and its complications is sort of an ever-present fear, ever-present danger, and is certainly a major source of stress and anxiety for both caregivers and clinicians alike. But fortunately, fatal events from acute neurotoxicity are relatively rare in the modern developed world. In countries where we have good medical resources, access to IV solutions, special TPN solutions, etc., it's pretty unusual to have a death from MSUD during the acute phase. But widespread and common is chronic neurodevelopmental problems that are rooted in sort of the day-to-day control of amino acid metabolism in particular. And one of the areas of study that has been a fascination to me over the years and has in many ways inspired some of the developments in medical foods is the role of the cerebral blood vessels in the chronic neurotoxicity. So this is a latex impregnation of the entire cerebral vasculature of a human brain. The human brain has the densest vasculature of any organ in the body. And many of you know that there's something very special about human brain blood vessels in that they have this special barrier we call the blood-brain barrier. And what this essentially means at a physiologic level is that the blood vessels of the brain are relatively impermeable to a large array of substances and express a series of protein transporters that selectively import or only selectively allow certain substances into the brain. This is critically important for amino acids. And there's a whole family of different amino acid transporters that are arrayed at the blood-brain barrier. And one of them that has been of special interest to me and of special relevance to MSUD is a transporter called SLC7A5. This is the official protein nomenclature, or gene nomenclature. Many of you will know this by different names. This was first coined the Y+ transporter and subsequently called the LAT1 transporter. It is a transporter for what are called zwitterionic amino acids, sometimes also referred to as neutral amino acids. Now, zwitterionic amino acids simply means that the structure of the amino acid has both a positive and a negative charge on it, but it is electrically neutral. For our purposes, what we need to know is that these amino acids are all roughly the same in size and charge, and so they can be carried by a similar structural transporter at the blood-brain barrier. Here is a sort of a cartoon showing the family of 10 amino acids that are carried by this transporter into the brain. They all compete with one another for a single transport site. Some of them are important substrates for neurotransmitters, such as dopamine and serotonin, that affect mood and behavior. It turns out that the 3 branched chain amino acids are members of this group of 10, and leucine in particular has a very high affinity for the transporter. That means that when leucine is high, it can effectively behave like a bully, keeping out all the other amino acids in the group. And a typical leucine level in a normal individual of approximately 150 micromolar. If that leucine level increases to about 700 to 800 micromolar, which is levels we commonly see in MSUD patients, it restricts the uptake of all the other amino acids to less than about 5% of normal, has a profound effect on the uptake of various amino acids in the brain. And so one of the sort of paradoxical things about leucine elevations is that leucine probably acts less like a direct neurotoxin and more as a mechanism that starves the brain of other essential nutrients, or causes a malnutrition of the brain for these other 9 substrates, including isoleucine and valine, which are branched chain amino acids. Over long periods of time, what happens is this imbalance of amino acid uptake by the brain can lead to profound structural abnormalities of how neural networks get formed. This is a classic neuropathology study that was published in 1992. It's a rare kind of a study in that, MSUD neuropathology studies in humans are rare to begin with, but this is one that involves some very, very elegant and very difficult staining of nerve cells. And you see here in the control subject on the left, a control brain, this is a actual image of the individual nerve cells in the cerebral cortex and their various extensions and connections. And you can see this is a richly interconnected network of multiple neurons. A comparable section from the MSUD brain shows that there's fewer nerve cells, they're smaller, they have fewer extensions, and many fewer connections. And this is really the biological substrate of things like intelligence, attention, memory. And so these are the sorts of long-term structural changes we can see in the brain from these chronic imbalances of amino acid uptake. So at the Clinic for Special Children, we've been able over a 30-year period to study the management and outcome of the world's largest cohort of MSUD patients. This is in part because MSUD, which is relatively rare worldwide, is comparatively quite common among the old order Mennonite population of the northeastern United States. The birth incidence of MSUD has been estimated to be anywhere from 1 in 250,000 to 1 in 500,000. Among the Mennonites of Pennsylvania, it's about 1 in 400 births. So the carrier frequency for a BCKDHA severe mutation is 10% among Pennsylvania Mennonites. And so we've seen quite a number of patients over the years. We recently published our experience in Molecular Genetics Metabolism. This is the reference. It's called a 50-year natural history study. It actually constitutes a 31-year experience at the Clinic for Special Children since we opened, but we had good retrospective follow-up data on patients actually well into their 50s, and we're able to compare outcomes among these groups. This cohort involved 184 subjects who were managed at our clinic for all or some part of their life. You can see here that the large majority of them had classic MSUD or a severe type. The light blue represents the Mennonite cohort. This is a BCKDHA 1312T to A mutation that essentially all Mennonites are homozygous for. You can also see we had a large proportion of non-Mennonite classic patients from all over the world. We also had 6 patients who had an intermediate or milder MSUD, shown here in green, and then 2 siblings who actually had an intermittent form of MSUD, which I personally didn't believe existed until I met these children. So intermittent MSUD is exceedingly rare, but it does appear to exist. Interestingly, this is a genetically diverse group. So although we do manage principally Mennonites with the biallelic mutations in BCKDHA, we actually have in our cohort represented over 174 different genetic combinations leading to MSUD. We have children with birth dates between 1963 and 2018, ranging in age, individuals from 1.5 to 57 years of age. So let's talk about dietary management. Most of what we know about dietary management in the current day really is rooted in this study that was initiated in 2005. This started as a collaboration with the Applied Nutrition Corporation and ultimately with Nutricia. And in this study, we designed a new medical food that was really built upon these concepts of amino acid transport. The medical food was designed to address some of the nutritional deficiencies that had been identified in MSUD, such as essential fatty acid deficiencies and some micronutrient deficiencies. But really what made this formula special was the unique combination of amino acids, which were really intended to safeguard the brain against this nutritional deprivation that's caused by chronic elevations of leucine. We studied this in a cohort of infants over a number of years. We published that experience in this paper. What I'll show you now is a follow-up of this cohort that we've now followed for the last 15 years. We did a data cut in late 2018 that involves 41 subjects. These 41 subjects were in between 2005 and 2018, were all managed prospectively in similar fashion using exclusively this new medical line of medical foods. So what we can see overall won't be a surprise to many of you. This is classic MSUD. So what you can see here in blue is the average prescribed energy intake from diet largely matches what would be the predicted energy demand. The predicted energy demand here is shown as the gray dotted line. This is from the National Science Foundation, what's called the doubly labeled water method, which is the most considered to be the most or one of the most accurate ways of quantitatively estimating energy demand. What you can see is that most of the patient's diet, certainly in the first 2 years of age, is prescribed, and that patients take a relatively small proportion of their total energy from table foods. This is reflected here in another way, and what you're looking at here is the relative percent of total protein equivalent that's derived from intact proteins, for example, table food proteins or natural milks, shown at the bottom as blue circles, as compared to the branched chain amino acid-free protein equivalent that comes from formula. And this is shown in the upper curve with the purple diamonds. And this is to really underscore how across the lifespan, these patients are highly dependent on their medical foods, deriving anywhere between 70% and 95% of total nutrition from their medical foods. And this is really the defining feature of classic MSUD and is not unlike what you would see in classic PKU. Now, one of the things that we use to really determine the severity of illness is something called the leucine tolerance. And leucine tolerance is defined as the amount of leucine in milligrams per kilogram per day that an individual can tolerate while still maintaining a normal plasma leucine level. Essentially, what leucine tolerance represents in physiologic terms is the amount of leucine the body uses each day to build new protein. To be more precise, it's the sum of leucine that's used to build new protein plus any what we call insensible leucine loss or insensible protein loss, which is protein that is lost from the body each day and is unquantified. This is the protein in hair cells and skin cells that are sloughed off primarily. And by the time you're an adult, that amount of leucine just represents approximately 10 to 15 milligrams per kilogram per day. What you see, not surprisingly, is if you follow leucine tolerance, it is essentially inversely proportional to the growth rate. And so newborn infants, and particularly babies less than 2 years of age, tolerate fairly high amounts of leucine, anywhere from 50 to 70 milligrams per kilogram per day. And this is really representing the very rapid growth rate. So the accretion of new tissue allows the body to tolerate a higher amount of leucine. Once children have passed their major early growth spurt, which ends at around 5 to 6 years of age, you can see on the blue curve, their leucine tolerance starts to flatten out and has really reached adult levels by about 17 years of age. Now, interestingly, this is a little bit complicated, but the message is important. Interestingly, we can keep leucine levels, shown here in blue, and also shown on the right-sided y-axis. So notice that this graph has two y-axes, a left and a right y-axis. Focus first on the blue solid line with the circles. That's showing you average annualized plasma leucine levels in patients relative to age on the x-axis. The gray area represents the normal mean and standard deviation plus minus 1 standard deviation for leucine in healthy non-MSUD subjects. So that would be our what we would call our tight normal range. So what you see is that we can control leucine pretty well with diet for the first 6 to 7 years of life during that rapid phase of growth. Children are more tolerant of leucine during that time. But as they get older, not surprisingly, because their leucine tolerance decreases, their growth rate decreases, and we start to see more problems with dietary indiscretion and adherence, the leucine level does gradually start to drift up. Notice the purple dashed line, which is the average number of amino acid samples sent per year, shown on the left y-axis. During the early years of life, you're getting amino acids from subjects every week or twice a week throughout those first 2 years. So you can see during that first year of life, the average number of amino acid levels we check is 65 in a year. So that's a little bit more than 1 per week. In some cases, going up to 85 to 90 in that first year. Now, we achieve this through a filter paper method. So we have established a method that allows patients to send in amino acids from home using dried filter paper blood spots. And this really facilitates doing these. But you can also see that as they get older, they send the levels in less frequently. And by about age 10 or 11, they're typically sending levels less than once a month. This is very characteristic of many metabolic disorders, a phenomenon I'm sure many of you or all of you are familiar with, is that metabolic control and adherence in general becomes more challenging as patients get older. Important implication of this is shown here. So what you see here is on the x-axis, the number of amino acid samples sent per year, which was represented on the y-axis in the last graph. And now what we've done is we've simply taken the annualized average leucine. So we've taken all the leucine values collected in that year, averaged them, and plotted them against the number of amino acids that were measured in that year. There is an inverse correlation between the two, and we see a similar phenomenon in classic PKU. Here's the important sort of take-home message of this, is this shows you that there appears to be a minimum requirement for amino acid sampling if you want to achieve reasonably good control in your MSUD patients with classic disease. If you want to keep the level within or close to the normal range, showed here in gray, you must be measuring amino acid levels at least every 2 weeks. If you're measuring amino acids less frequently than that, you can be assured that you're not getting optimal metabolic control. So let's talk here about dietary management and the outcomes that we can expect with that in sort of the modern era. So as many of you know, older patients with MSUD who were managed before the advent of really high quality medical foods, before the advent of newborn screening, many of them have had very poor outcomes. Severe intellectual disability, spastic diplegia and quadriplegia, severe mood and behavioral problems. And this is common in our older cohort as well. But what I'm going to show you here is really the outcomes we can expect in the era of newborn screening and with the correct or appropriate use of modern medical foods. So one of the things that we found in our cohort that has been really one of the most dramatic changes for patients in terms of quality of life is that the combination of improved medical foods, higher quality medical food, mixed with higher rigor of surveillance, more frequent outpatient amino acids, has led to a really profound decrease in the hospitalization rate. So when we opened our practice in 1989, the average hospitalization rate for MSUD patients in the Mennonite population and in the classic MSUD population that was under our care was about 7 days in the hospital per patient per year. This included some hospitalizations that were quite protracted. It was not unusual at that time for newborns with MSUD to be admitted to the hospital sometimes for 4 to 8 weeks in the immediate postnatal period. You can see that over the years with these gradual improvements in care and surveillance, the hospital rate has gone down to just 0.3 days in the hospital per patient per year. Now, in the cohort that we've managed since 2005, 41% of them have actually never been hospitalized, and not even as newborns. So many of them were picked up for either from newborn screening or from targeted testing of umbilical cord blood at our laboratory, managed at home through the perinatal transition, and essentially never had an acute encephalopathy. This is a 45-fold overall reduction in hospitalization rates. This alone in our population saves the MSUD population about $8.5 million a year in medical costs. Another important general parameter of outcome or general measure of outcome is growth. Obviously, with metabolic disorders, particularly those that involve the restriction of essential amino acids. We're very sensitive, very mindful of the potential effects on growth. What we've been able to document is normal somatic growth in our prospectively followed infants, shown here. That's weight, this is length, and then, and most importantly, head circumference. So we know that prior to the advent of modern therapies, many patients with MSUD had acquired microcephaly. That was acquired as some combination of metabolic toxicity, but probably chronic essential amino acid deficiency in the brain as a result of high leucine levels. For many of you that follow the work of Urine Manole, a good friend of mine, and her work at the NIH, you're now well aware of the fact that improper or overuse of medical foods can actually be a cause of acquired microcephaly because of amino acid imbalances. And she's documented this very well in cobalamin C and MMA. And certainly we have seen the same phenomenon and published the same phenomenon in MSUD. But we would not expect that with thoughtful modern treatment. We would expect that we should see normal brain growth. Also, along these lines, we should expect normal milestone acquisition. So this is looking at the acquisition of standard WHO milestones in our cohort of 41 infants and children followed since 2005. You can see here in blue, this is the percent achievement of a milestone going from upper left, sitting, crawling, walking, and climbing stairs. The light blue is the MSUD patients. The gray shaded area is their age-matched non-MSUD siblings. So these are developmental records from the siblings of the patients, very closely matched for genetic background and upbringing, etc. And you can see essentially there's no significant differences, that these MSUD patients achieve major milestones on time in lockstep with their siblings. Cognitive development is a bit of a different story, and one that is in some ways an important cautionary tale. So in this cohort, we did IQ testing, Stanford-Binet version 5 testing, on a subgroup of MSUD patients and their age-matched sibling controls. This graph is a little complicated, so I'm going to take a moment here to explain what you're looking at. If you look at the x-axis, you'll notice that the x-axis is expressing the score as a percent of the sibling controls. So the scores were all normalized to a matched sibling. So you'll see that the gray line going up the middle represents the 0 point and the neutrality point. That would be where the point would fall if a MSUD patient and their age-matched sibling had exactly the same IQ score. On the y-axis, you'll see the subdivisions or subdomains of the Stanford-Binet. There are 8 subdomains that we measure: memory, going from top to bottom, memory, visuospatial, reasoning, quantitative reasoning, fund of knowledge, fluid reasoning, verbal IQ, nonverbal IQ, and then full-scale IQ. FSIQ, or full-scale IQ, is what we're most accustomed to looking at when we look at IQ reports. But it is constituted from these different domains. So what you see is we had done extensive IQ testing in an older cohort of patients born before the advent of these new medical foods and prospective therapy. This is a group of patients that we have managed that had birth dates between 1967 and 2004. And the important point is that all subdomains of intelligence are affected by MSUD, are negatively impacted by MSUD, and that on average, MSUD patients will have a full-scale IQ of 40% lower than their non-MSUD siblings. This is a pretty alarming statistic. If you think about that, what that means is that the average IQ in this cohort will be somewhere around 60. And that's certainly within the intellectual disability range, and most people with an IQ of 60 will be highly dependent on others for daily day-to-day life skills. We see that if we now look at the younger cohort that was managed prospectively, this group of 41 from 2005, we've almost improved that by a twofold, in that now we're seeing IQ decrements of approximately 15 to 20% in this cohort. I think that the way I would look at this graph and the way I've talked about it is that I think this graph tells a mixed story. I think it tells an important story of the major improvements that we've been able to accomplish with closer surveillance and higher quality medical foods. We've been able to really improve cognitive development in these patients. But I think it also shows us the limitations of what we've been able to do. I think it shows us that even under the best of circumstances, our dietary therapies and our current standard of care still leads to suboptimal cognitive outcomes. And this just is a rallying cry to me and others that there's more work to do here. So I do want to just finish off briefly with liver transplant. It's something that some of your patients will ask you about. I know it is not necessarily a focus of this particular webinar, but I do think it's important because I think it's part of the picture of MSUD, and I think that we need to acknowledge its role in the modern world for the treatment of MSUD. I think it also tells us something important about enzyme regulation and biomarkers for MSUD that we can use as clinicians, as dietitians moving forward. So liver transplant has an interesting history. The first two liver transplants that were done for MSUD were done not as a way to treat MSUD, but as a way to respond favorably to patients who had liver failure and also happened to have MSUD. The first case that I'm aware of was done in France in 1993. It was a patient who I believe had a liver cancer, although I don't recall the indication for liver transplant, also had MSUD. Patient received a liver transplant, and the MSUD appeared to be cured from the liver transplant. This was a serendipitous finding. It was not an expectation that this would happen from the transplant, but the authors did publish that experience. We had a patient who had a similar problem. We had a patient, a Mennonite patient, who developed hypervitaminosis A, who developed acute liver failure from vitamin A toxicity that had been acquired as a result of taking some natural supplements that were very, very high in vitamin A. This is showing you her amino acid levels, her branched-chain amino acid levels, leucine, isoleucine, and valine, in the 12 days prior to transplant. And you can see this extreme volatility in the gray shaded area. She had a liver transplant, and all of a sudden, her levels normalized. And in fact, they normalized in the face of a completely unrestricted protein intake. So based on this experience, a number of years later, we started to explore the possibility of elective liver transplant for those patients who were non-adherent to or had problems staying on nutritional management. That program has grown over the last 17 years. We have now experienced transplanting 95 classic MSUD patients, both Mennonites shown in blue and non-Mennonites shown in purple. And what you see here is you see that statistically the rate of transplant, although it appears a little higher in the non-Mennonites, it's actually similar statistically. These are not different curves. And that you see that by about age 40, we can expect that approximately 70% of MSUD patients are going to choose liver transplant over dietary therapy. This is the metabolic outcomes from liver transplant relative to dietary therapy, and this is very interesting in my view. So just to orient to this graph, you'll see the y-axis shows you plasma concentration of the branched-chain amino acids. Branched-chain amino acids on the x-axis are grouped with leucine first and isoleucine then valine. The four colored symbols represent in gray squares control individuals. So these are non-MSUD individuals. The blue circles are patients with classic MSUD managed on dietary therapy. The purple diamonds are patients with intermediate or milder forms of MSUD managed with dietary therapy. And the red diamonds are actually patients post-liver transplant. So a few things to point out here. One of the things I would encourage you to just all see, which is interesting in my view, is that the average branched-chain amino acid levels, in fact, average leucine, in the classic and intermediate patients is the same. So having intermediate MSUD doesn't mean necessarily that you'll have lower leucine levels. It means that you'll have similar leucine levels, but with a higher protein intake. And we see this in our intermediate MSUD population, is the patients with intermediate MSUD do tend to self-liberate their protein intake to maintain their leucine levels at the upper limit of normal or just above the upper limit of normal. But you can see there's less volatility in their amino acids. The other thing I think that is important to recognize here is that even the liver transplant patients, if you look at just the leucine now, the first four columns on the left, even with liver transplant, the average leucine after liver transplant is not much better than you achieve with diet. But what is much different is the standard deviations. So you lose the volatility, you lose the extreme variation that you see with dietary management. And keep in mind, the other major difference in terms of quality of life is these are the levels in liver transplant patients who are on a completely unrestricted diet. And that's really what, from the patient's point of view, has the biggest impact on life quality for them. Interestingly, as I'll show you on another slide, this issue of unrestricted diet is often one that is more important to the patient than to the clinician, and I'll show you in a slide how that plays out. This is very instructive as well, and it's something that we have focused quite a bit on as a biomarker over the years. This is again showing you the same convention of control in gray, classical in blue circles, intermediate MSUD in purple triangles, and then the red diamonds representing the transplanted patients. Here you're looking at the ratio of valine to leucine in plasma, the molar ratio. So this would be the valine concentration in micromoles per liter divided by the leucine concentration in micromoles per liter. What you see in gray is that normally an intact branched-chain ketoacyl dehydrogenase enzyme complex regulates these ratios within very narrow limits. Whether you're fasting, whether you've just had a high protein load, whether you're dehydrated, the relative concentration of leucine to isoleucine to valine in the blood is always held within tight limits at a ratio of about 2 to 1 to 4. And that is the maintenance of those ratios is a very important indicator of intact enzyme function. And what you can see is this is a log 10 scale, so that shows you it gives you some idea that this is varying over orders of magnitude in the classical patients. When you do a liver transplant, you really reduce that volatility, you really introduce a level of regulation to amino acids, and this is actually very important for overall control of brain uptake of the various amino acids. The other thing we see as a marker of intact enzyme activity is alloisoleucine. And it turns out that alloisoleucine can be pretty informative. Alloisoleucine can be measured by many commercial labs. We measure it in our laboratory. There are other CLIA-certified commercial send-out laboratories that measure it quantitatively. And if you have a question in your mind about whether your patient is a classical or intermediate MSUD, you can use the plasma alloisoleucine as one other marker of this. It tends to be lower in intermediate patients and is undetectable in about 75% of patients post-transplant. Finally, I want to get to this idea of protein loading. So just as an experiment, we took heterozygous parents of affected MSUD patients who had been transplanted, and the parents are shown in gray squares here, and we gave them each a leucine load, a protein load of 10 grams of protein or more in one sitting. And we looked 45 minutes and 4 hours after this meal, and we simply showed that patients with MSUD, liver transplant, they tolerate very large protein loads. But you can see that on average, their branch chains are a little bit higher than normal. They don't completely normalize. They're at about 2 times the normal level. Finally, this is looking at full-scale IQ prior to and greater than 1 year after liver transplant in a series of about 15 MSUD patients. And the important point is here that it doesn't change. So if you have patients who are considering transplant at any time in their life, an important message to them is that transplant does not reverse any brain damage, any behavioral problems, any mental health problems, anxiety disorders, paraplegia, any of those existing pathologies going into transplant persist after transplant. And in our clinical population, this realization has led to a phenomenon which is really not driven by us, but has been driven by the patient population, that people are getting transplanted at a much younger age. So what you're looking at here is on the y-axis is the age at which someone was transplanted relative to their date of birth. And so you can see that in recent years, children are getting transplanted at younger and younger ages, in large part, I believe, to try to avoid permanent brain damage that may occur in the setting of acute neurotoxicity or chronic neurotoxicity. We recognize all the limitations of liver transplant. There are significant morbidities that go along with it. It is a very serious and dangerous procedure. And so the way we present it is we give patients sort of the 2 options and to weigh the risks and benefits, and then help them go down whichever path they choose. But we recognize it's imperfect, and we're hoping that with the advent of DNA-based therapies, in particular gene therapy, mRNA therapy, there may be even better solutions in the future for these patients. So with that, I'd just like to thank all of my wonderful coworkers at the Clinic for Special Children. I am very blessed to work with an exceptionally dedicated and hardworking and creative group of people. I want to thank my collaborators at Nutricia who have been very supportive of the work over the years and have been wonderful partners and advocates for our patients. And also my colleagues at the University of Pittsburgh Medical Center and the transplant team who also have become really extraordinary advocates for patients and team members over the years. So thank you for your time and attention. In the time that remains, I'll be happy to take questions.
Wonderful. Thank you so much, Dr. Strauss. Really interesting data there. So I do have a couple of questions that folks have typed into the chat. Y'all continue to type those in while we talk through these. And then following questions, I'll provide instructions on how to complete the event survey and obtain continuing education for today's webinar. So my first question is whether you monitor allo-isoleucine.
That's a great question. So we measure allo-isoleucine on our standard amino acid analysis. So it comes out as part of our normal chromatogram, so that every time we measure branch chain amino acids, we actually get an allo-isoleucine level. However, we don't monitor it as an index of metabolic control because it really doesn't have any relevance for neurotoxicity. So if you're monitoring to look at leucine tolerance, to make dietary adjustments and so forth, the allo-isoleucine is not helpful. Where allo-isoleucine is helpful is as a diagnostic aid. So in the initial workup of a patient who maybe tests positive for newborn screening and has sort of equivocal branch chain results, or occasionally you'll see patients who come in with ketoacidosis who have had elevated branched-chain amino acids, and the question is raised about whether they could have MSUD or an intermittent form. In that setting, alloisoleucine is extremely useful as a diagnostic tool. A patient who does not have detectable alloisoleucine simply does not have MSUD, and sometimes that can be the defining arbiter of whether they have MSUD or not. So from that standpoint, it is helpful, but not for long-term management.
That's great. I think you sort of answered a part of the second question that we got, which first of all was a thank you, and then said, since you're noting, that carrier parents can have leucine levels at the upper end of normal, is it then possible that an MSUD carrier could have an abnormal newborn screen, even if not affected?
I can tell you that I think the answer is no, and here's why I think I can say that pretty confidently. We have a very large number of carriers in the Mennonite population. Remember, 10% of Mennonites are carriers for MSUD for classical form, and there's about 80,000 Mennonites living in Pennsylvania. And we have never once had one of those heterozygote carriers test positive on newborn screening. So I think that's a pretty good natural experiment that tells you that we would not expect, even with classical mutations, we would not expect a carrier to test positive on newborn screen.
Excellent. Thank you. Here's another question we've got. So understanding that your lab has the capacity to do blood spot, which allows for more frequent amino acid monitoring. For centers without this, capacity, do you see a place for checking urine ketones? Does this have a role in your clinical management at all?
It's a great question, and it's one that comes up often. So for many years, we used DNPH reagent. We actually synthesized DNPH reagent in our laboratory. We've gotten away from doing it for three reasons. One is DNPH reagent, which measures alpha keto acids, is relatively toxic. It's made from concentrated hydrochloric acid. It is also unstable, so it's a reagent. Its chemical reagent properties decrease quickly over time, becomes unreliable, and it's also highly subject to urine concentration effects. So you can see a patient with relatively normal branch chain levels in blood who will test strongly positive for DNPH first thing in the morning when they're relatively dehydrated or their urine is concentrated. And then after having breakfast and a couple of glasses of water, it turns clear. So we found that it is just not very reliable. It's not a very good marker of plasma control of amino acids. And keto acids would be similar if you use keto sticks in the urine. The problem with the keto sticks is they can be useful if you suspect a patient has an acute intoxication at home and you want some verification of that before you tell them to come to the hospital. But usually by the time the keto sticks turn intensely positive, the patient is pretty encephalopathic. And so it almost tells you what you already know. The other problem is that it tests for all the keto acids, and it's really only alpha ketoisocaproic acid that's toxic. You may see beta-hydroxybutyrate being elevated. That can and often does correlate with elevations of leucine, but not in a way that's highly reliable. So that's a long way of saying we don't really use the keto sticks. I think, unfortunately, it's just too blunt of an instrument. I had a teacher in medical school that used to tell me that treating MSUD is a little bit like trying to play Rachmaninoff with boxing gloves on. It requires a level of precision and rigor that is difficult to achieve with a lot of the clinical tools that we have. And keto sticks and DNPH is a good example of pretty blunt tools. I think that, unfortunately, for centers that have trouble getting amino acids done, I think the right answer is the hard answer, which is you got to figure out how to get amino acids done more frequently. You got to work with your hospital labs, your hospital administrations, to make it easier, more convenient. Try to see if you can develop a filtered paper method. The filtered paper method is not difficult. It's more a matter of just getting hospital administrators and laboratory directors to accept it. But it's the protocol itself is very easy, and we're happy to share it with anybody.
That's great. Thank you so much. We're going to do just a couple more questions here. I've got one that says, thank you, Dr. Strauss. Do you see increases in leucine tolerance in patients who are very active with sports?
Good question. Typically not. You can see higher turnover rates. So let me be kind of specific about this, because this is very relevant to patients who get through an acute encephalopathy. So often what we'll see in patients who exercise frequently is they'll have higher degradation rates of protein and higher synthetic rates around a similar set point. And what that often leads to is, if they're exercising heavily, for example, a weightlifter or somebody doing football practices in summertime, they will experience often large elevations of leucine or transient elevations of leucine. And then if they take 2 days to recover, that leucine will drop more quickly. They'll have transient leucine tolerance as muscles being rebuilt. But if you average their leucine tolerance out over long periods of time, you don't really see a change in leucine tolerance. There is an exception to that, and that would be any athlete who's on anabolic therapy. So anybody taking testosterone or growth hormone or any so-called illicit anabolic therapies, they will have a higher positive leucine tolerance because they're accreting net muscle tissue. Most athletes are turning over muscle tissue but not accreting a lot of it, if that makes sense. The other point I'd like to make is, when you see patients who come in and they're catabolic, and you treat them over the course of a hospitalization with anabolic therapy, and you decrease their leucine, for example, from 1,500 down to 200, often for 2 to 3 weeks after the hospitalization, they have a very high leucine tolerance. In infants, we've seen leucine tolerance go up 50, 80% in those 2 weeks. So there appears, after an acute illness, to be sort of a rebuilding or recovery phase where they can tolerate a lot of leucine. And in those cases, you just have to feed the fire, basically. You just have to give their bodies what they need.
That's great. I'm going to leave you with one final question. Do you have any insight as to when gene therapy might be available?
I do have some. I left my crystal ball in the trunk of my car, but let me try to give you an update on what's happening here. So this is an area that I have a pretty intense interest in. We've done some, we've been involved in some other gene therapy trials. MSUD is a high priority condition for us, and so we are actively pursuing, with collaborators in Massachusetts, we're actively pursuing a gene therapy development program for MSUD. And we have some preclinical work we've done on mice and patient-derived fibroblasts. We are actually moving in the next year to some preclinical experiments in MSUD cows. For those of you who are interested in veterinary medicine, you may know that there's a naturally occurring classical MSUD calf, first discovered in Australia in the Black Hereford line, that biochemically exactly mimics human MSUD. We are pursuing some studies for gene therapy in those calves. MSUD in principle is a perfect target for gene therapy, for AAV therapy in particular, because there's a large reservoir of enzyme in muscle and liver, and those two organs are typically hit very well with AAV vectors. So that's a long way of saying I think it's around the corner. The problem is I don't know how far in advance that corner is. When you consider regulatory problems and so forth, I would guess that you won't see first-in-human gene therapy for probably another 4 to 5+ years. But I do think, I am optimistic that I'll see it in my lifetime. I think it will. I think it will definitely. I think we will see it in the not-so-distant future.
That's great. Well, thank you so much for speaking today, Dr. Strauss. And thank you to everyone for attending. We're going to wrap things up here. This is just some final information on how to receive CE credit for today's webinar. Please complete our survey. You'll automatically be routed to the survey page when you close the webinar out today. Alternatively, you can access the survey now with the QR code you see on the screen. To do this, just open your smartphone camera, hold it over the image of the code on the screen there, that squiggly box. It'll prompt you to open your phone's web browser and take you directly to the survey link. The survey itself contains the CE code, which you'll need to enter into nutritialearningcenter.com, and this will then allow you to download your certificate of attendance to your Nutritional Learning Center profile. And with that, we will finish things up today. Thank you so much to everyone, and we hope you have a wonderful rest of your day.
Thank you so much. Thanks, everybody.